Many of the people in this audience are leaders of hospitals and health systems, and many of those are not-for-profit organizations. One thing that is at their disposal is the community benefit dollars, and we expect that there will be some freeing up of those dollars with coverage expansion. Historically, community benefit has been anywhere from 7, 8, 9% of hospital operating revenues. The bulk has been devoted to uncompensated or undercompensated care, but with the coverage expansions, we expect some of those dollars could potentially be redirected into the community. What would you suggest that they do? What if you're in a community that doesn't have a quarterback? Where do you begin? Should hospitals be working together and pooling their resources and trying to leverage many of the other sources of capital that you've talked about? Can you give us a little bit of insights as to where they begin? What's your advice?
So I think partnerships are key, and I think even places that don't have a quarterback will have a community development partner there. So I was talking to it was a children's hospital in, I think it was Kansas City, saying, well, they really saw the need to finance upstream interventions like better early childhood experiences and whatnot. And so we decided to create a community development financial institution, a subsidiary of our own hospital. And I thought, that is so difficult. You don't build your own computers or your own ambulances, right? You partner with somebody that does that, because it's hard. That's a hard business to figure out. And so everywhere that you all are, there are community development partners who know their communities, who have buy-in from the local community, and have technical know-how that can help you deploy those dollars.
Excellent.
I'm Mary Jean Shank. I'm from Wayne State University. I'm actually in the business of medical education. But I thought one of the most powerful slides I saw was the poverty slide, and the concentration of poverty in what is the fastest growing population in the United States. And I'm wondering, as we do these investment strategies and ROIs, how many generations do we really need to support and promote and continue this in order to actually see a change in these poverty statistics? I mean, what's your estimate on that?
So typically poverty in the last 100 years or so has followed very closely with the business cycle. And what's changing now is a disconnect from that. And so you're seeing poverty rates, which even during times of good economic times, the early 2000s, say, you still saw a rise in poverty. And what was even more disturbing is the number of people who live at below half the poverty rate, what we call deep poverty, has gone up by 200% over the last 20 years. And what you're dealing with in those situations are multi-generational poverty, where the number of sort of social pathologies that are overlapping are so massive that you really need this coordinated, all hands on deck type intervention. But what's amazing is when you do that, I am not kidding, the school in Eastlake, which was a place where the graduation rate was about 30% before purpose-built went in, when they did this comprehensive intervention, it went up to 80%. And that school is one of the 5 best performing schools in the Atlanta School District. And it's very similar, not entirely exactly the same population, but very similar population. So we know that those kind of interventions work. What we don't know how to do is replicate them and finance them at scale. And that's why the way Wellville is so important, because if we can think about additional funding sources, we can do more of those kinds of interventions.
I would just add, one of our communities is Spartanburg, South Carolina, and they started out as one of their goals to improve college graduation rates, and this was linked to poverty. And what they realized in continuing to peel that back is that they needed to get earlier and earlier in the process. So then it became high school graduation and college readiness, and now they're focused on pre-K. So. And there are ways actually through impact investing to bring new capital to the table to fund pre-K programs, because there are substantial benefits, we know from the evidence, to investing in children early on. And so this whole new impact investing, social impact bonds, pay for success movement is really around, this is a horrible term, but I'll use it, monetizing the value of that early investment in childhood education. And it's actually underway in a number of places around the country.
My shorthand for that is the status quo is stupid and expensive, and we can do better.
George Isham, Health Partners. So I'm wondering, are you talking about public health and community, or are you talking about what the healthcare system needs to do to reach beyond healthcare delivery to enter into those markets and return better value to the American public? You know, it's something that leaders need to think about in terms of what business they're in. If they're in a business called healthcare, which really isn't affecting, you know, a lot of the impact, and yet one could have alternative scenarios where we invest more appropriately in public health and so forth. So I think that might be an interesting question for you to think about. At least I'm curious about what you think about that.
I'd say just really quickly that if you switch over to a business model where you're managing population health, I think you have a lot of partners that you may not know about that will be very helpful in executing on that. And I think if we focus on the places where they're driving a lot of the costs in the system, low-income communities, I think we've got a lot of prototypes that are really promising.
John Bluford, former hospital executive, recently retired. I really relate to a lot of the things that each of you are talking about. I grew up in South Carolina, and I spent many years in the Twin Cities. But I'm squirming in my seat here, David, particularly at your map and the poverty map. Mm-hmm. And it's very obvious to me that there is a preponderance of poverty in slave states, formerly slave states. And I think the other little pocket was probably New Mexico, I'm not sure, but I would venture to guess it's a Native American site. So if in the context of some of the sociological underpinnings that we talked about earlier, what kind of research have you done on the impact of slavery and how it affects the healthcare status of many Americans today?
So I don't know many studies that have done that, tackled that question squarely, but I would say that what's very troubling is if you're in Atlanta and you're low-income white, you're 1/3 as likely to enter in your life in the top quintile if you're born in the bottom, if you're white, as a black person born in Seattle. So there is something about those places they are not opportunity. The opportunity structures there are weak for all races, and I don't know what the answer is to that question, but we do know we could probably get a real delta of health savings if we very much focus on the Southeast, where we have such terrible health outcomes.
Wayne Lerner, also a recently retired hospital executive. I think we're starting a trend here. I'm really curious, and I have the same question about the previous presentation. My last position was the CEO of a faith-based, not-for-profit safety net hospital. 30% of the patients had no insurance, second highest rate of foreclosures in the state of Illinois, on and on. I'm thrilled that people are finally paying attention to social attributes, but I'm very concerned that issues as violence, jobs, education, economic security, lead-based paint on the walls are not taking enough attention here, because if you think about the 2080 equation, most of the challenges are in the population that I was serving or that John was serving in Kansas City, and I'm curious as to how you factor that into your equation.
Well, for us with Way to Wellville, we're measuring total population outcomes, and so we know that the communities we've selected know that they won't be successful if they're just focusing on a particular subpopulation. And really, 5 years isn't a long time, but it's longer than a 1-year grant or a 2-year grant. So there are some opportunities to begin to tackle, some of the fundamental underlying issues. And that's really what each of the 5 communities has done. Niagara Falls, New York, it's a social determinants of health plan. Spartanburg, I mentioned, they're focused on pre-K. In Greater Muskegon, they're focused on job opportunities. So I think, and this was deliberate in our selection process. We were really looking for communities that understand that if we want to make a fundamental difference and create new models that can be replicated, then we need to dig down underneath the surface and begin to address those more fundamental issues and find ways to finance that that go beyond grants and philanthropy, because we don't think that's sustainable or scalable. And the health system needs to be part of that journey in What is the business model for a total population health health system?
Just real quick, probably should have said, by the way, that the views I shared with you today are my own and not representing the Federal Reserve System. So, and I should say too that, you know, the bottom line is we all win when we all win. And the statistic that it really burned in my brain about that is, in 1965 there were 5 workers per 1 retiree. Today there are 3, and by 2030, when most of the baby boomers are retired, there'll be 2. And one of those 2 workers will be Black or Hispanic, and you saw the numbers I put on the board about the poverty rates in those communities. Those 2 workers are going to have to be hyper-productive in order to keep all these systems running, and we've got to make those investments today. And I think people are coming around to that. I think there is a change in thinking.